Welcome, welcome, welcome everyone. Welcome to Care Concierge with Carepatrol, where education is the heart of everything we do. Carepatrol is an aging care navigation company or placement agency. We work with clients who are in crisis situations in the hospital or in rehab, or who are in planning stages of finding aging care that's appropriate to their needs and their budget. And then when we find such providers, those providers pay us a commission. So we're free to our clients. We've been operating since 2011 and have 4 employees. And we'd love to work with you if you have clients or friends who are just needing to ask questions. We're happy to do that as well. Today, we are going to be joined by Dr. Sipma. She is with the UAB, Department of Neurology, the Division of Movement Orders. And she will be sharing for us Huntington's disease, overview and pearls for managing late-stage disease. And this is a presentation that some of you may have noticed we've done in the past. It is part of the UAB Center for Excellence and part of their need to distribute this information to as wide a swath of people as possible. And I think that you all are a terrific wide swath of people for this information. She is in clinic this morning and is running a bit behind, but I'll tell you a little bit about us, about our housekeeping. If you're new to us, we have an evaluation process that is password protected, and we give the password out at the end of the presentation, and that allows our social workers to claim this Zoom event as a live or face-to-face event. Nurses, we will post your hour for you on the Alabama Board of Nursing site, who credentials us. Social workers, the board prefers that you post your own. And here is Dr. Sipma is joining us momentarily. So again, our password protected evaluation link, I'll read for those of you who aren't able to see the screen. It is https://www.surveymonkey.com/all uppercase letters, B as in boy, T as in Tom, N as in Nancy, 6 Q X. That's the evaluation link. I will post it again in the chat room. If you don't know how to access the chat room, take your cursor and move it to the top of your screen or to the bottom. At one or the other, a bar will pop up with the word chat. You simply click on it. You also have the ability to unmute your mics and ask Dr. Sipma questions, or you can post them in the chat room and I'll read them for her. I'm going to be admitting her and getting her started here in just a minute, excuse me. Here she is. Dr. Sipma, my co-host, yes. So Dr. Sipma, if you can hear me, if you can unmute and turn on your camera, I have your screen pulled up that will allow you to go through the slides, or you can, as a co-host, pull up your own screen.
Great. Yeah, I can share my screen. I have everything pulled up here as well.
Okay. Which do you want to control your slides instead of me?
Yeah, I think that'll just be a little easier. Then way you don't have to keep clicking on stuff too.
Yeah, let me see if I can unshare. Well, I'm sorry, I don't know how to unshare. What a boo.
I think usually if you if you're presenting to usually the top of the screen, there should be a drop down. There should be an option to stop
So
sharing.
there's a
the screen.
pause share, so I've paused it, but it still seems to be there. Let's see what happens if you try and share. Multiple parties. There you go.
All right.
And Dr. Sipma, this is recorded. I hope that's okay with you. We
That is
allow
fine.
our participants and encourage our participants to ask questions. They have the ability to unmute their mics, or they may post them in the chat room, at which point I will try and find a convenient spot to interrupt and ask you their questions. And I'll let you begin. I'd love to hear, again, your history, because I think it's kind of interesting.
All right. So my name is Dr. Sipma, Rebeka Sipma. I'm originally from California. Kind of grew up there in an area called Parkinson's Alley, because there's a lot of pesticide use. And so very familiar with Parkinson's side of movement disorders. I came to Georgia for undergrad at Covenant College, where kind of fell in love with medicine, went back to California to be closer to family during medical school and my residency. So I went to Loma Linda for my medical training, and then I did residency split between the University of California, San Francisco's Fresno campus, and then UC San Diego. And then my husband's been here in Alabama for the last 2 years, so we joined back up together again. And I'm now very happy to be the first year fellow at UAB in Birmingham here, and then I'll be staying on for a second year of fellowship when I get to do a little bit more kind of elective clinics next year, and then hoping to stay on here as faculty in the years following that for the foreseeable future. So again, Huntington's disease is part of this movement disorder spectrum. And so we see a lot of Parkinson's, we see a fair amount of Huntington's disease. Birmingham's got a really good multidisciplinary center. So I've been learning a lot over this last year here with our team, as well as, previous experience at San Diego. So today we'll be talking a little bit about some of the pearls for managing kind of more of the late stage disease process here for Huntington's. So we'll go ahead and get started. All right, so a little bit of an overview here. We'll do a little bit of an intro, and then we'll kind of cover some of the symptoms, usually the Huntington's disease triad, which covers the motor, behavioral, and cognitive symptoms. And then we'll go into a little bit of the medical, psychosocial issues, safety, and then some real world scenarios and summaries here. Okay. A little bit of an overview on Huntington's disease. So it's what we call like a prototypical pure genetic disorder, meaning that if you have the abnormal expansion of the Huntington gene on chromosome 4, then you will inherit the disease if you get that gene. But if you did not get that gene from your parents, then you will not get the disease. So it's kind of an all or nothing in regard to if you have the disease or not. And then it's passed down in an autosomal dominant pattern, meaning that there's kind of a 50-50 chance of, if you get the mutation passed on to you, again, you'd have the symptoms, versus if that other 50% you don't get it passed on, then you wouldn't have the symptoms. So the gene codes for a specific protein called the Huntington protein. And when you get abnormal buildup of this protein, then that becomes very toxic to brain cells. The normal brain on the left-hand side here, these kind of darker brown parts in the middle are the caudate, and those are very important for our circuitry and movement in particular. And you see that's a lot less over here on the HD brain, as well as just kind of overall, you do have a little bit more loss in some of the other areas too. And prevalence, it's a worldwide disease, so there tends to be a little bit more increased prevalence in some of the areas where they've had maybe founders or patients with the gene reproducing a little bit more. And so here in the US, we have about 300,000 total patients with Huntington's disease. In Alabama, it ends up being about 300 patients, and kind of on a worldwide, so out of every 100,000 people, maybe 4 to 7 are going to end up having Huntington's disease, kind of worldwide average. And then typically age where patients start noticing symptoms or can kind of tell they're having some early signs is about 30 to 54 years old. And the age of onset very much is related to the number of the CAG repeats in that gene. And so the more repeats you have, the more likely it is to have an earlier age of onset compared to a later age of onset. So usually we're making the diagnosis when you're an adult with the start of chorea, which are some of those normal involuntary movements. Can also be though with psychiatric symptoms presenting earlier too. We confirm this usually with the family history, kind of getting a detail as to if there's known Huntington's or known symptoms in other family members, and then following up with genetic testing to look for those repeats in the specific Huntington gene. Unfortunately, there's no treatment currently available to slow, stop, or reverse the progression of the disease, though that's really much that's the aim of a lot of the clinical trials that they're doing. That's what everyone's hope and goal is we want something to reverse this, and they're working on it, but nothing that's approved or quite been that magic bullet quite yet. Unfortunately, that does usually occur about 10 to 30 years after the onset or when you're becoming symptomatic. This is variable, and there's a lot of other factors that can kind of contribute to that. So it's not a hard and fast, it's a pretty wide range, as you can see, from 10 to 30. All right, and then Huntington's disease and long-term care facilities or assisted living placements. So many families are going to turn to long-term care facilities. And that's usually later stages in Huntington's when individuals are completely dependent on others for care. But depending on, family resources, social setting, they may be admitted earlier in the disease if they just can't provide that care at home, or again, something else happens in the family and there's really just a need for other people to help with that care. And compared to a lot of the typical residents who are going to be living in these long-term care facilities, your Huntington's patients are going to be a bit different demographically. So usually, again, they're going to be younger because, again, this disease is starting in 30s to 50s, where a lot of the other things like dementias or Parkinson's disease are going to be starting 60s, 70s, 80s, 90s. And then with HD, it does not have any predisposition to males versus females. So both women and men can get this equally. And then in addition to the kind of cognitive impairments, there's also a lot of severe movements. So if you think about like Alzheimer's or dementia, there's not a whole lot of other movements. It's mostly patients are confused, a lot of cognitive decline, versus the chorea with Huntington's can get severe in the later stages. And then psychiatric or behavioral disorders are also very common in Huntington's disease compared to some of the other comorbidities or things that might lead other patients to needing the long-term care facility. And usually with Huntington's patients, there's not a whole lot of other medical diagnoses on the admission. So it's not a whole lot of, long-term high blood pressure and heart disease or cancers or other things going on. It's really this one disease is doing most of the damage to a lot of our patients.
Excuse me, Dr. Sipma, we have a question from Tanya Jackson is asking, what is its relationship in comparison to Tourette's syndrome?
So Tourette's syndrome is also a movement disorder, but they're different in the fact that Huntington's is coming from this genetic disorder, which is causing chorea, which is a very specific type of abnormal movement, as well as a lot of other brain changes. Tourette's syndrome does not have a genetic link, so they would not have the similar CAG expansion. Tourette's syndrome tics are a different type of movement disorder, and so it is similarly irregular and kind of higher amplitude like some of the chorea, but there's also a kind of a sensation of needing to do either the tic or the movement or the vocal expression that you can feel it coming on. You can sometimes suppress it, and then once you unsuppress it, then that tic comes back worse in Tourette's syndrome. Versus Huntington's disease, patients don't have that urge to move or that inclination that you need to move or sense of relief when you do that movement or the behavior. It's kind of an involuntary, your body's gonna do it whether you are thinking about it or want to or not. Versus Tourette's, there's a little bit more of control over the movement. And then treatment too is going to look a little bit different because chorea medications don't may work for some of the tics, but not all of the tic medications will work for the chorea and the Huntington's disorder. So there's a little bit of overlap because they're both movement disorders in the way we'll try and symptomatically treat them, but they don't have the same genetic basis, the same abnormal proteins, and the same kind of psychiatric comorbidities.
Thank you so much.
Of course. All right, and so kind of in the literature, some of the caregiver handouts that you might read from our different organizations, you'll see kind of early, middle, late stage Huntington's disease described. When we're getting into the late stage of Huntington's disorder, this is characterized by the need for 24-hour supervision and care. Patients are then dependent usually for feeding, bathing, dressing, toileting, mobility, etc. And then again, because there's so many different levels of care needed, usually this is when families are looking at long-term care facility in order to help out with all of that care around the clock. We use a United Huntington's Disease Rating Scale, which has a couple different components that we look at when we're visiting with patients in the clinic. And one section is the total functional capacity score. And so that rates kind of how independent are you in some of these activities. And usually late stage HD is going to be characterized by a score of about 0 to 2. The normal score of, person living at home, not really impacted in their ability to care for themselves in any way, would be about a 13 is the normal, the highest you can get. So 0 to 2 is shown a fair amount of decline in their ability to do things independently. And then kind of depending at what TFC was at the time of diagnosis. So some people don't start at that normal 13. They might start at, a 12 or 11 or a little lower. So on average, patients end up reaching the 0 to 2 or the late stage HD about 15 years after diagnosis.
Dr. Sipma,
Mhm.
what is the capacity for falls? What is mobility like for the patient?
So usually mobility in the later stage of HD is going to be pretty impaired. And so again, some people start out with early falls. And so that might be a little bit more early in their disease process versus later stage HD. You might be needing more wheelchair or bed bound or some of those other kind of less mobile. In particular, you need help with transferring, so patients might need lift chairs or some other assistance in order to get themselves safely from one location to another.
Okay, that's what I was sort of thinking. So I know you're somewhat new to Alabama. Just so you know, a Huntington patient would not qualify in assisted living in Alabama.
I know we've got a big social work team and a lot of multidisciplinary people who help kind of work on what's available for everybody here. So, and each state and each insurance is a little bit different in what they cover and what things qualify here too. So, and we'll get a little bit too, and we'll go into detail with some of the triad symptoms here a little later as well. And so, so kind of the 5 areas of disease progression that we'll typically look at on a clinic assessment is, again, mobility. So it may start as difficulty walking, progressing to kind of bedbound in those later stages of Huntington's disease. Feeding, again, starting out eating independently, using utensils without any assistance. Last, end stage would be needing a feeding tube. So that's a hole into the stomach where we're able to put a liquid nutrient into the stomach directly and not necessarily needing to use the muscles in the throat, which can also be affected by the movement problems. Continence, and so that's the ability to manage your self-hygiene in the initial stages versus later where you become incontinent or unaware of needing to go to the bathroom, even that have gone to the bathroom. Communication also starts decreasing. And so communication initially, clear sentences, able to make your thoughts heard well, mute, or some of the other things we'll cover in some of our later symptoms as well, becomes more common in these later stages. Participation is the other key area that we'll assess, and that's how interactive and engaged with activities. So kind of alert and able to interact with everything versus non-interactive, not really fully aware of the environment or participating in conversations or care, things like that. So we'll go through a little bit more in detail on the symptoms of late stage HD now that we've gone over that overview. So many of you are probably aware, so the triad of HD symptoms include motor symptoms, psychiatric symptoms, and cognitive symptoms. And so the motor ones, those are some things like the involuntary movements, which are the jerky movements called chorea, impairment of voluntary movements as well. And so that's, the difficulty using utensils, that's the difficulty walking. And then psychiatric, most commonly we see depression. Patients will also describe impulsivity, kind of, not thinking about things that before they do or say them. Apathy is kind of a lack of enjoyment or a lack of motivation to do things. Irritability, like having a short fuse, feeling more on edge a little bit. And then obsessionality, so kind of perseverative thoughts, thinking the same thing over and over, getting fixated on an idea or a schedule or something, some part of their disease process can also be seen. With cognitive, so the most common things are kind of reduction in speed and flexibility of thinking. And then kind of what we call executive function is this difficulty with planning and prioritizing. And so kind of keeping track of appointments or thinking, okay, I need to do this thing before I do this other thing, or, this thing that might not be normally important to another family member suddenly is like the most important thing to this family member with Huntington's disease now. So as we'll talk about here in the late stages of Huntington's disease, all of these things will require both medicines as well as non-medical treatments. And so that's where this multidisciplinary care really comes into effect as well. A little bit more on the motor stages. So we've got chorea is, again, that abnormal kind of jerky movement. Dystonia is where you have an abnormal hyperactivity of a muscle. So that can be things like if neck muscles are hyperactive, you get kind of pulling in one direction. With hands, you can get abnormal posturing in particular, or curling in, which can be painful if it's too tight in some directions. And then Parkinsonism. And so Parkinsonism is this combination of slower movements, not quite as fast as they normally are, more stiffness as well, is kind of the typical things we see with Parkinsonism. Orally as well, so you get motor dysfunction in the muscles in the mouth just as well as you do in the arms and the legs. And so the way you see these manifestations is through speech becoming more slurred or more garbled or harder to understand. Similarly, there's a lot of muscles that are involved in swallowing. Again, under normal control, you aren't thinking about that. You're just kind of automatically getting saliva to go down. When you're eating, people can often, talk or multitask and not have to necessarily think about the swallowing. It just happens automatically, versus in a lot of our movement disorders, this process breaks down and you have to start thinking about how to get the food in the right place, how to get it down appropriately. And you can have some of these involuntary movements due to the chorea affecting those muscles where they just aren't going to do what you want them to do, regardless of how hard you're kind of thinking about it. And so then as well, we talked a little bit about ambulation being a big part of it, where you're kind of going from independent of not using any assistance devices like cane or walk to needing more and more help with those things. And then activities of daily living. So that's things like, brushing your teeth, getting dressed, bathing, etc. So a little bit more on some of these details. So chorea typically is going to be the most severe about 10 years after symptom onset. And then kind of later is when some of the patients might develop more of the dystonia, which is some of the abnormal positioning of movements. There is, again, some variability in this. Some patients who don't have disease onset until their 70s or 80s might start with having chorea, and that's mostly what they get is the motor symptoms. So there might be like initial onset early on. And then again, dystonia kind of is the main thing we're looking for that, is because it can cause discomfort. And so if it's present, then we want to start trying to treat that as best we can. And with Parkinsonism, when you get rigid in particular, that's stiffness of muscles, which can also be very uncomfortable for patients. And so we want to be aware of that and making sure we're addressing it as best we can. All of these things contribute to some impairment in mobility. And so if we have medications where we can reduce the amount of chorea or dystonia or rigidity, then sometimes patients' mobility can improve a little bit as well. And so kind of one of the myths previously was that chorea is not worth the trouble for late stage Huntington's patients. That's really not true. We can get a lot of, quality of life benefit from treating the chorea. The main ways that we can do that right now are these medications, which are covered under the term VMAT2 inhibitors. The longer names are tetrabenazine and deutetrabenazine. You might have heard more of the brand names. Austedo is the one that we use most commonly now, and then exenazine is the tetrabenazine one. So FDA approved tetrabenazine back in August of 2008 for Korea, and it's been generic since 2017. 2017 is also when this other medication, deutetrabenazine, got approved. And so tetrabenazine does have a generic, which can make it a little cheaper. It does carry more side effects. The improvement with the deutetrabenazine is they changed how the medicine is formulated slightly. There's another kind of addition to the structure of it, which means that there's a little bit less in the way of side effects, which is why it's better tolerated, but it is still brand name. And so it is a bit more on the expensive side, and we often have to do some other paperwork in order to help reduce the cost for our patients. And so the VMAT2 inhibitors should be are still going to be available at long-term care facilities. And so the pharmacies can deliver these to the facilities in blister packs or however the facility prefers to receive it. It's hard because these ones just aren't on formulary, meaning most of them just don't carry them in-house for patients to have as needed. So usually it does need to come from a specific pharmacy and get sent to the facility.
Excuse me, Dr. Sipma. I'm curious, how much is this medication?
I'm
sorry, you may not know. I guess you've never purchased it.
Don't think I know off of the top of my head. Because usually our pharmacist has been good about
$15,000 or $100 or
if Ziola's on the call, she might know off the top of her head, but let me see if I can find it.
Oh, Ms. Jackson has a question. Do these individuals also have history of seizure events?
So seizures, I would say, are usually more rare in Huntington's disease. Seizures can come from a lot of different things. And so it's hard to make generalizations because not everyone who has seizures is going to have Huntington's disease. Not everyone who has Huntington's disease is necessarily going to have seizures. As like a general overview, a lot of our neurodegenerative processes can carry a higher risk of seizures in general because you just have more of the brain tissue dying off. If more brain tissue is dying off, then you get more abnormal signals, which can produce seizures. So, and let me see if there's a.
Ms. Brown looked it up for us. She said that these medicines are, in her research, costing $4,800.
Yeah, $4,800 to $5,000 is looking like the typical cost from like some of these other locations here.
Goodness, how do patients afford that?
Usually you don't unless so what we sometimes say in clinic is unless you're a pocket millionaire, you won't be paying for it. There's these other programs that are set up, which we just have to go through the paperwork in order to get approval for. But with the right approval, then patients are paying $0 for this. So.
Okay. We did a CEU on that where pharmacies actually do, or pharmaceutical companies actually do rebate you or give you, less cost drugs, less costly.
Yes.
That's great.
And so I know there's like GoodRx and there's other ways that our pharmacist is, again, patient programs that we're able to get them approved through. So you're paying $0, but they otherwise would be costing several $1,000s a month. So it's not our most expensive medication in neurology, but again, a lot of these can add up very, very quickly, especially if you're thinking about, we said Korea starts, over maybe 10 years before it gets to its most severe. And so we're thinking about, these medications for decades potentially for patients, depending on when they're coming to us and getting diagnosed and needing the medication. So it can add up quite a bit.
Ms. Brown, who had given us the price, also says her dad has Huntington's.
Yeah, so I'm sure you're very aware with the costs that can come not just through medications, but through some of the other parts of care here as well. So thank you for contributing there.
Well, Ms. Dean asked, are there research trials available to offset the cost of, I guess, any medication or treatment? And then Ms. Bullock had asked, and you may not know this, Dr. Sipma, she asked, do the long-term care facilities, can they use the copay or patient assistance cards or rebates?
So yeah, usually, again, I think there's a coordination between, it's usually a conversation between insurance, the long-term care facilities, and the like the drug companies. And so I think there is some paperwork where it can reduce their costs because, again, insurance is requiring them to pay for these patients. And that's one of the reasons sometimes that long-term care facilities who aren't set up or aren't familiar with the process might be a little hesitant of this might be an increased cost if we're not able to get some of those extra funding, right? If they're having to foot some of that bill. So that's answering one of the questions. Research trials. So these ones are the FDA approved medications, right? So FDA approval means it's been through several rounds of clinical trials. And if a medication's in a clinical trial, it's not yet available for purchase. So if you're part of a study that is looking at a medication, there's no cost to that medication. It is applied as part of the study, which is why pharmacies or pharmaceutical companies are putting a lot of money into these research projects because they're funding all of the medications, they're giving it to all of the patients, and then it's usually about a 10-year process, typically we say, from like identifying a medication to actually getting it approved by the FDA. Because it has to go through the trials of, is this safe? Does it cause any harm to patients? Is it effective? Is it actually doing what we want it to do in a patient or a person? And then, is this better than what's out there currently? Like, is it producing actual benefits to quality of life, to reducing comorbidities or death or things like that? So it's usually years and years of research and trials and getting patients these medications in these trials before we're getting to a point where they can be on the market and be sold. Again, your generic ones are going to be more expensive because only one company has access to that medication and can produce it. Once it's generic, you open up some of the competitiveness, and so other companies can produce it. It becomes a little like a race to see who can produce it for cheaper and cut down on their prices, because then they're going to get more business. And so that's kind of the benefit of why we want to get generic medications sooner rather than later. But again, that's all part of the FDA labeling and approval process too. That most of the questions, I think that covered some of the questions there.
You did a very admirable job. You answered everything.
Perfect. All right, so we'll move on to some of our other medications that we'll use for chorea as well. So a lot of the times with our medications, if people are being treated for stuff, you're going to end up with accumulating lots of medications. If we can, we want to try to use one medication for two or multiple reasons, right? And so some of those ones that we can use for multiple purposes are our antipsychotics, meaning that they help with some of the psychiatric problems that patients are having as well. But then side effects, these antipsychotics also work in motor systems in the brain. And so then they can help block some of these extra movements in the chorea. And so some of the ones that are really good at blocking some of these movements are ones called haloperidol, fluphenazine, and perfenazine. If patients who don't have Huntington's disease are on these medications, oftentimes doctors will also use a medication called benztropine in order to block the side effects of problems with movement. But in Huntington's disease, we actually do want that side effect, and so we won't use the extra medication. But doctors who aren't familiar with that process, who always just use them in combination, might not be aware of like that's a target that we're actually trying to use in our treatment for Huntington's patients. And then we also have these, what we call atypical antipsychotics, risperidone, olanzapine, ziprasidone, also very effective for our psychiatric symptoms. They have a little less of a chorea reduction, but they can also reduce it to some degree. It's just a little more variable and maybe not as much as some of these other medications. That's just based on how strongly they bind to receptors, in particular in the brain. And so kind of a comparison of our typicals versus atypical antipsychotics. So the ones that are typical, again, have more of the motor symptoms. So you do have an increased risk of tardive dyskinesia. This is often abnormal mouth movements, kind of like puckering or moving the mouth abnormally, lip smacking, etc., because another motor pathway is activated. Other symptoms that you can commonly have would be dry mouth, what we call orthostatic hypotension, meaning when you change positions, you have a higher drop in your blood pressure than normal. And then Parkinsonism, so that's more of the stiffness and the slowness, and then dystonia, so again, the abnormal posturing or the tightness of muscles in particular. So those are more common with our typicals versus our atypicals, tend to have more metabolic or kind of overall systemic symptoms. So those are things like weight gain. Metabolic syndrome is a resistance to insulin, so having some abnormal blood sugar levels as well. And they're a little bit more on the sedating side. And so those are side effects that we're looking for. Again, we don't want to cause too much in one direction versus the other. In some patients who are losing a lot of weight, again, the weight gain might not be too bad of a side effect, right? And so we're looking at the whole patient and deciding which ones are benefits that we can get from the medication and which side effects are ones that would be, better for this patient compared to some of the other medication options. And then non-medical treatments, right? So there's other things besides medicines that we're doing in order to increase protection and safety for patients who have chorea. So those are things like weighted utensils, so you're able to hold on to those a little bit better. Padded bed rails help prevent injury from, flinging arm or flinging head and hitting against something hard. It gives a little bit more of a cushion. Again, you'll have padding in your seats and wheelchairs in order to prevent breakdown if you're sitting in one position for too long. Longer cords, again, are a tripping hazard or things that you can get caught on with involuntary movements. And so trying to remove those as best we can. Some like hospitals or places where patients are having abnormal movements, the inclination is, if they're moving too much, we need to use some sort of restraint or, tie it back so they don't hurt themselves. But that can actually do more damage in your, again, going against a restraint and end up causing more damage in that regard rather than just letting it happen. Keeping an eye out for bruises and abrasions too is very helpful because we don't want to, let injuries go unnoticed. If there's something bigger going on, we want to make sure that's addressed as well. And then, so the severe or what we call ballistic is very large amplitude, huge movements. And so if the patient is falling or running into walls, things like that, then you might want to think about using padding like elbow pads, knee pads, etc. And if they're having trouble falling out of bed, then getting the bed closer to the ground can be helpful as they're not falling quite as high of a distance either. And then this is an image of what we call a U-step walker. So this is designed specifically for Parkinson's disease, but it works very well for our Huntington's patients. So we use it for our ataxia patients. Really, any person who's got a neurologic walking abnormality can potentially have some benefit from this type of walker because of the way it's designed. So it's got more of this U-stepped base, which is where the name comes from, which helps provide a little bit more stability. So it's unlikely to tip over if the patient is going over, like those just standard gray stand-up walkers. You have a seat here with a backrest if patients are getting fatigued or need to sit down when they're out and about. For Parkinson's, they have this cueing module with a laser, which is helpful for freezing. With Huntington's may not be necessarily the most helpful, but if they're having some freezing, which can come from the Parkinsonism side of HD, it might have some benefit as well. And then there's usually a little basket here underneath too, so you're not carrying things and dropping things. And then with the handle brakes, so most walkers are just they're going to go, and then you have to use the brakes in order to lock it. This is kind of the reverse. If you need to actually hold on to those handle brakes in order to go. So if you let go, if something happens, the walker's not going to keep going without you. It's going to stay there until you come and grab the handles and get it moving again. All right, and so some of our other movement problems with HD we'll talk about a little bit more. So dystonia, again, like in the neck or the hands or other limbs, we'll often use Botox injections that helps relax the muscle to some degree. Better if it's just, one muscle or a small area. If it's a larger area, then we start getting to the point where we're needing too much Botox and that you can cause weakness and other problems from that. And so it's better if it's just a small area that we're using some of those injections for specifically. Parkinsonism with rigidity in the bradykinesia. So we can use a small dose of Parkinson's medications called carbidopa-levodopa, or we might try and reduce the dose of the tetrabenazine or the antipsychotic or the Austedo, because all of these can contribute a little bit to the slowness and stiffness. But again, we're trying to balance out which is worse. Is it the chorea is worse or the Parkinsonism, and how can we kind of best balance those for each individual patient? So in summary, kind of these all do have effective medical treatments. So make sure you're kind of having doctors assess, what are the main symptoms for your loved ones. And if they're having those, again, kind of figuring out which treatments might be the best options for them as well. And if they're at a long-term care facility, again, they should have directors who can work closely with the nearest center providing care, center of excellence. All right, and then a little bit more on the speech and swallowing. So again, we talked a little bit about with the speech becoming more difficult, you get less communication of needs and even mutism. That can lead to problems where, patients are not getting the care that they need, right? And so we want to be aware that patients may not always be able to tell you what's going on with them. Other problems we run into with the swallowing issues too is if they're choking and getting water down into the lungs instead of down into the stomach, then that can lead to infections. It can also lead to weight loss if they're not getting the food, as much food as they need down into the stomach. This leads to what we call failure to thrive and can ultimately lead to death if it's not treated to. And so we want to keep an eye on weight and how well their nutrition is doing. Things that can help with both the communication or with the communication specifically. So we have communication boards, which speech therapy can help assess for and give recommendations for. And so that can be simple, just standard, board or something that's going to be the same every single time, or there's other computer-based or digital options. So things like iPads, where again, there's more options, clicking on things or selecting things and stuff like that. And this can be helpful for communication of needs or again, participating in care as best patients can to improve their autonomy. And then a couple of different things with the swallowing and drooling pearls. So if drooling is becoming a lot bigger issue, especially during the day, it can be really irritative to the mouth. It can be embarrassing, or it can even you lose a lot of fluid that way potentially. So we do have medications for that if it's becoming an issue. One of the ones we'll commonly use is actually eye drops, because it's supposed to help dry out the eyes, but it also works well with saliva. And so we'll use these eye drops just applied to the tongue a couple of times a day. Scopolamine patch. So if you're seasick or motion sick, this is another thing that we'll use for that, but it also works well to help dry up the mouth. If really severe, then again, Botox is a toxin that we can inject into the glands in the mouth to help dry up and produce less saliva over time. If patients are having trouble swallowing liquids, then main things we'll try to use then would be straws. You're using a little bit different of muscles in that way. And another thing is thickeners. And so it gets more of this thick, not quite jello, but more of a solid consistency to it, which makes it easier to get to the back of the throat and all the way down. And then dysphagia to solids. Again, speech therapy can help assess, is there certain food textures that are a little harder for the patient to swallow? Is it drier foods? You need it a little bit more moist, etc. And then helping with the chin tuck. So chin down towards the chest while swallowing does help kind of move food back and down. And so it helps with the mechanics that we don't necessarily think about when things aren't going wrong, but in the cases of dysphagia are actually really important. And then if patients are having weight loss, some things that we'll try to implement as best we can would be 24-hour access to food, having snacks available, increasing things like salt and butter and sugar, which for, normal American probably should be cutting back on, but for our Huntington's patients, those higher calorie things are going to be helpful in keeping their weight on and preventing other complications. Big part of this is, again, having that speech therapist evaluation and the multidisciplinary clinic assessing what things might be best. All right, and then other loss of independence for ambulation. Again, we've covered a little bit of the U-step walker. It can be helpful, but if getting into the later stages, the walker still might not be enough. And so they may be progressing to the point of needing a wheelchair and something else to help give them a little bit of mobility, but without taking away all of the independence, but giving them more safety. And then things around like activities of daily living. So there's modified utensils, which can be helpful. Things like having a bedside commode, so they're still able to get to a toilet, but it's not necessarily going all the way across the room, or going into a hard, very tiled bathroom where if they fall, they're more likely to have an injury. Things like shower chairs can also, again, provide some seated areas where they're safer, but still able to complete some of those tasks. Physical therapy, occupational therapy are super important in assessing and giving recommendations in this regard. And so we like to have them involved early and frequently. All right, moving on to some of the cognitive stages of late HD. And so dementia is, again, the inability to complete tasks because of cognitive decline. And so it's very different from Alzheimer's disease in that, Huntington's patients can still understand words compared to Alzheimer's disease patients might not always understand what's going on. And it's just more of a slower processing with HD. They also have impaired judgment, and so might not pick the right thing at the right time. Disorientation to time is more frequent, so harder time keeping track of days or what time of day it is. And then again, communication can often impair what they're wanting to say or trying to say, so it might seem more profound. Unfortunately, with the cognitive symptoms, we don't have clear medical treatments for HD yet. So big things for this is planning ahead. So starting to talk with the patients before dementia is clouding their ability to communicate or understand what's going on, discussing how would you like to be cared for, getting specific documents, so like advanced directives, physician orders for life-sustaining treatments. Those sorts of things are really important earlier rather than later. I'm a big fan of everybody should be talking about this with family members, whether you have HD or Parkinson's or heart disease or anything. Everyone should be very open about this, but unfortunately it's not a very talked about part of our society. But it's better to have patients' ideas of how they want their care known sooner rather than later. And then to communication. So as they're able to communicate more, starting to pick up on what are likes, dislikes, what are body language cues specific to my loved one that I can help kind of be in tune with. And then teaching those to everyone who would be caring for the patient, if there's home caregivers or other family members helping provide care. And then understanding even when patients aren't necessarily communicative with you back, they're often still understanding what's going on. And so being careful how you're talking to them and still talking with them, because they're still understanding. If there's a lot of apathy or withdrawal or kind of that lack of motivation, then we'll first off assess for depression, because mood can similarly appear to be like apathy. And then your doctor may consider the addition of something like a stimulant like Ritalin or Adderall, which can help, provide a little bit more energy, a little bit more of alertness. It may not always be the fix, but it can sometimes be helpful.
Mrs. Brown, Kimberly, who spoke earlier, said that the HD clinic at UAB is amazing, has truly changed my dad's quality of life. Huge support system for us. So helpful, so knowledgeable.
Yeah, so there's a lot of different providers. And so with more providers, we help give different expertise and different angles, which is why we're a big proponent of these multidisciplinary clinics in particular. And then, so other big thing too, so that sleep-wake cycle is really important. If patients aren't sleeping well, then a lot of your other symptoms can get worse. This is true for Huntington's disease, as well as a lot of other neurodegenerative disorders. So even small disruptions in sleep that you're previously able to compensate for can become a lot more problematic, cause a lot more confusion and other issues. So oftentimes doctors will look at timing of sedating medications to try and keep the sedating ones that make you more sleepy towards the end of the day and avoiding those during the beginning of the day. Keeping patients active and engaged during the day is super important for maintaining this alertness too. So trying to keep activities like exercise and other things earlier, and then keeping a bedtime routine as well, to kind of stimulate tell the body that this is now nighttime, this is time to help get ready for bed, those hormonal cycles as well. During the day, it's important to try and keep naps less than 30 minutes when you can to help to avoid this disruption. It becomes more difficult, but as best we can. That's some of the important things there. Let's see, and then how am I doing on time? We'll go through some of the behavioral symptoms as well. And so if present, this is what causes a lot of the family distress and a lot of difficulty in caring for the patient. So as we talked about earlier, depression, anxiety can be a big part of it. Paranoia, or kind of the suspiciousness or suspecting family members are doing things. Obsessiveness or perseveration, again, hyper focusing on something in particular. Explosiveness or outbursts of anger. Impulsivity, doing things without thinking, as well as screaming, again, can be all very difficult for patients and family members. So with depression and anxiety, we have a number of different medications. Again, our picks will depend on what other medications you're on. Counseling is another big part of it. And so there are counselors who are trained in HD. If you come here to our clinic, we have little handouts with codes in order to get you into one of those counselors. Other resources available too are a big part of our targeting depression and anxiety. These other ones, the paranoia, suspiciousness, the delusions, the other part are a little bit more difficult to treat with medications. And there are different medications that we'll use. Usually the antipsychotics are more helpful in this one compared to the ones we use for like depression, which would work both for depression and anxiety, but not necessarily always treat the other parts of it. Big things that family can do is distraction. And so if they're becoming very paranoid or obsessive, trying to provide other things for them to do, engage them in other activities or other things that they like to do can also help bring them away from whatever paranoia or obsessive or explosion they're kind of undergoing there. Recognizing patterns and identifying triggers is another big thing too, to help try and limit those as best you can to kind of prevent as much of the explosion or irritability or other things too. Impulsivity will oftentimes look at more of a mood stabilizer, which is a different type of medication. And then we'll use environmental strategies. So things like if they're getting up and wandering, we'll have a alarm kind of on the bed or the seat. So caregivers or family members are aware of they're getting up and maybe going or doing something that they're not supposed to be doing. Screaming in an otherwise mute patient, where patients have stopped talking overall. This often is a kind of a terminal stage of the disease, meaning we're very close to them passing away at that point. It may not be to discomfort. Patients, family members are very concerned that their family members in pain, and we don't want them to be in pain. So we'll double check for pain, infections, etc. But it might not always be the case. It might just be the brain is deteriorated, and this is one of the ways it's showing that. If it's present, that's when we're talking more with the hospice care and some of the palliative care doctors about kind of end stage and what things we can do to just focus on comfort at that time in particular. All right, and then we'll try and hit some of these other issues as best we can before time runs out. So aspiration pneumonia, that's when you're getting food or water down into the lungs instead of down into the stomach. So making sure you're watching for, is the patient choking a lot, clearly like coughing after eating or drinking, and then having a change in mental status, meaning they're, more confused or sedated. Fever might not be there even though they have an infection. And so that's what makes it hard to always catch early. And then abandonment is another common psychosocial issue. Hereditary nature of HD can make it very difficult for patients and family members kind of emotionally. It can be hard to see a loved one kind of going through all of this with the worry or the concern of like, is this going to be what, I have or my kids have or other family members are going to be going through emotionally or physically later. With patients not moving as much without walking around, they are at higher risk of clots forming in the legs, which can then go up to the lungs and cause breathing problems. So clots in the legs are going to be evident with some swelling, sometimes redness or pain in the leg. And then we have prevention measures like compression stockings and other things to help increase the blood flow, so you're not getting so much of that blood just sitting there and forming big clots. Weight loss, as we discussed earlier, you want to try and adjust to higher calorie foods. Again, talking about as a feeding tube, something that your family member would want or not, because some people would never want that. Other people would be like, that's, if I get to that stage, for sure, I would want to be doing that. So with safety and autonomy, it's kind of this delicate balance of we want to be watching out for the patient's safety, understanding that they might not fully be aware of all of their limitations, but also wanting to respect their wishes, right? And so it's hard when they may not always understand the risks of everything that's going on. So best option when possible is, again, to discuss these issues ahead of time in advance. And knowing, with this aspiration, when you have this severe choking, would you want the tube? Would you want an infection to be treated? Or if it comes to that, would you say, nope, just comfortable at that point and enjoy the time that we've got left? Again, are they refusing the wheelchair, knowing that it's unsafe for them to walk where they might fall and break a hip or have a head injury? Refusal of food or medications, again, can be a hard point for caregivers and family members and patients. And similarly, we talked about restraints, right? There's some danger to restraining and causing more injuries, but there's also the dangers of falling out of bed and hitting your head against the wall or things like that. And so it's really going to vary by each individual patient. And so it's really based on those conversations of what would you want in this situation. And then some additional resources that I would really encourage you guys to look at. So the HDSA has several publications. You can download. All of the ones here are downloadable. I checked those out earlier, again, to confirm. And so they have kind of detailed guides of like what symptom wise to expect, kind of like what we went over. They have additional thoughts on, again, long-term care facilities, insurance, how do you kind of fund some of the caregiving later in life as well. And then kind of also the roles of like, talking with your social worker, with your speech therapist, your physical therapist, and your doctors about different things in particular. It can give you more of those good talking points or questions to ask when you are being seen.
Lacey Vincent is saying that this presentation has been so informative. Thank you for the wonderful information. I work with hospice, so this information has been great.
Well, thank you so much for your work in hospice. It's very, very important for many of our patients there as well. All right, and then thank you to the whole team. So this is a lot of the people that I've been learning from this year. Our doctors, our nurse practitioners, our pharmacists, social workers, and all of the therapists and psychiatry as well. So thank you for joining in to learn more about HD. And again, hopefully this is very useful to you.
Well, it's been terrific. Here's another comment. Thank you. This was great information. I'll second that. You were terrific, Dr. Sipma, and I'll make the open invitation. If you have other topics in neurology that you'd like to present, we'd love to have you back. Tiffany Taylor says, thank you. Donna Stevens, this was very informative. Darla Dean, greatly appreciate the information. I think we're all sort of blown over. Let me give, for those who are used to doing so, our password and our link to our evaluation, which is password protected. The link is https://www.surveymonkey.com/r/ all uppercase letters, B as in boy, T as in Tom, N as in Nancy, 6, Q, Q, X. And the password is excellence with a capital E, as in UAB is a center for excellence for the study and treatment of Hodgkin's disease. And Dr. Sipma, who spoke with us today, is a very important part of that team and research. Nyasha Hoover says, thank you. And I'll second that. We're at the end of the hour. Dr. Sipma, is there anything else you'd like to add?
Just a big thank you to Dr. Sung, who also helped with the development of all of these slides as well. So I've been learning from some of the best. So happy to pass on this information.
We're so lucky to have UAB and have folks like you who come here to enrich us. Thank you again. Thank you everyone for being here. We will conclude March's series of CEU events. We'll return on April the 10th and be looking for that schedule on our email, on our website. And I'll bid all of you a terrific rest of the day.